Well, thank you for this invitation, and I have no conflict of interest apart from being the only neurosurgeon in the room. Um, some background information about what's happening with spine surgery in Australia. Uh, these are the numbers of neurosurgeon in Australasia. It's 247 and approximately 12 trainees per year, 51 in Victoria. Here we have the number of orthopedic surgeons in Australasia, 1,400 with 58 trainees per year and 270 in Victoria. So basically, there are more orthopedic surgeons in Victoria than in the whole Australasia compared to the neurosurgeons. But the neurosurgical practice is mainly spine, and this is what we learn during the training. We learn to do laminectomies, discectomies, anterior cervical discectomy and fusions. There is no neurosurgeon in Victoria that can afford to be a pure cranial surgeon, basically because we don't have enough patients to do that. But what happened with spinal surgery over the last 20 years? Well, from 80% of spine surgery done by orthopedic surgeons in the 90s, now 80% of spine surgery is done by neurosurgeons. If you look at the competencies during training, a final year neurosurgical trainee would be able to do a laminectomy or a discectomy because they get involved in at least 300 operations during the training, while most orthopedic trainees wouldn't be able to do a laminectomy on their own, basically because they don't have the exposure to that pathology. Last year in the Neurosurgical Society annual meeting, there was a neurosurgeon from America, from Florida, coming to talk about what neurosurgery has brought to spine surgery. And he talked about the microscope, which is certainly a very good tool, and I use that pretty much every day, but hasn't really changed the outcome. So if you compare the same operation done with a microscope or without the microscope, there is absolutely no difference. And that's been done several times. He talked about neurophysiology, which I haven't used in the last 2 years, so no one really used neurophysiology apart from scoliosis correction. Keyhole surgery that, again, hasn't shown to be better than any other open technique. He didn't talk about what orthopedic surgery has brought to spine surgery, and that's internal fixation. And this is probably where spine surgery changed with internal fixation. Now we can do much more aggressive decompression, we can fix fractures, we can fix tumors that we were unable to do before internal fixation, and also fusion techniques. So it seems that orthopedic surgeons have the lead on the change in spine surgery, but the orthopedic surgeons, for some reason, are not interested. As Lou said before, we have more patients with back pain and with hip pain, and we have more hip surgeons. Shera said in the last 10 years in Victoria, we have only 2 new spine surgeons from the orthopedic side, while neurosurgeons are coming every year, 1 or 2, to do spine surgery. So those are my thoughts of why spine surgery doesn't attract orthopedic surgeons anymore. I think part is the patients. They are more difficult to deal with. They are more unsatisfied with the outcomes. The operations are longer. I think there are better opportunities in other fields. I guess there are enough hips and knees for all the orthopedic surgeons. There's probably too much competition from neurosurgeons, I guess. Patients, I think, tend to prefer neurosurgeons because when they come to us and we say that we do the operation with a microscope and we are very careful, we were training microsurgery, I think that they like to have all this technology. But I think the main point is the lack of proper training during the training program. Unless a trainee goes to a dedicated spine service, a spine surgery in Victoria, wouldn't get to see much spine surgery. And on the opposite side, what neurosurgeons find is there is less cranial work to do. Before we have all the vascular stuff like aneurysms and vascular malformations, and that's been taken over by endovascular surgeons or radiosurgeons. So they give radiation to the vascular malformation. There's no need for an operation anymore. I think this is a better remuneration from spine surgery. So a subdural hematoma takes 1 hour, which is the same time that takes simple decompression or discectomy, and the discectomy would pay 3 or 4 times more. There is an increased demand of spinal consultation in private rooms. So if I open my rooms today and I advertise myself as a pure cranial surgeon, I wouldn't see a patient at all. And if I advertise myself as a spine surgeon, then my waiting list will fill up very, very quickly. Also, the balance between the cranial and spinal training during the neurosurgery training program, we get to clip 1 aneurysm every 15 cervical discectomies. So, which means at the end of the training, most trainees are not confident to operate on the head, but they are very confident to do simple spine surgery. Problem comes when they try to do more complex stuff. And on the orthopedic side, I think we had less surgeons. They had very few in Victoria, but they are all full-time spine surgeons, and they are competent to do any operation from the front and from behind. We, unfortunately, neurosurgeons cannot offer that at this stage. And the other thing is changing that many neurosurgery trainees are thinking about doing spinal fellowship, and that is different from 10 or 20 years ago, where everyone wants to be a vascular surgeon. So they are going overseas or even here in Australia to spinal fellowships. And they prefer those run by orthopedics and neurosurgeons in conjunction, because that's where we really need exposure to all the spinal techniques. This is a paper we published back in 2009 on the learning curve for pedicle screw fixation. This is a learning curve for any operation, actually. It shows like 3 stages. The first stage where we learn the technique and we learn the basic movements. And the third stage where we're really confident with this technique. This paper, with all the limitations of a retrospective study, showed that to be confident with pedicle screw, internal fixation with pedicle screw, we need to get involved in 25 cases. So unless we provide the trainees the opportunity to get involved in, let's say, 20 cases, they're not going to be really confident to do a spinal fusion. Then my question was, is the background important? Is a difference if you're a neurosurgery trainee or an orthopedic trainee? I'm currently working on thoracic fractures, and we did the analysis of 218 pedicle screws done by 4 neurosurgeons and 5 orthopedic surgeons. So I have all the data in my hands. I'm not planning to publish this, but I just run a fish exact test in 2 groups. I'm not going to tell you which group is which, but one is neurosurgeons and the other one is orthopedic surgeons. And look at the difference. This is a rate of misplacement, 17% and 15%, and there's no difference. But then when I did the same test in 2 groups, where group 1 were mixed orthopedics and neurosurgeons with more than 10 years experience, the rate of misplacement was 13%, and both with less than 10 years experience was 18%. That was very significant. So it seems that experience is the key to get the proper training, which is quite obvious, but the training program may not reflect that. Then how do we overcome this divide? I think the combined post-fellowship Ortho-Neuro training programs are the key. I had the opportunity to do that at the Austin Hospital for 2.5 years. I certainly got more from the orthopedic side because I wasn't familiar with that than from the neurosurgery side. But there are only very few of these programs in Australia. I think the Austin one is probably it's probably the only one, actually. So I think the common forms of discussion for cases is another good option. We should probably think about elective rotation from trainee in ortho or neurosurgical units. For the neurosurgery trainees to be more familiar with the management of the bony fusions mainly, and probably the orthopedic trainee to be able to repair a dura if they have dura tear during laminectomy. And I think the future is probably a dedicated training program for spine surgery, which other countries in America, there are a few. We know that the spine is different from orthopedics and it's different from neurosurgery. I think with some extent we should probably look at have a dedicated training program with a few years just doing spine. Thank you.
Thank you.